يقلب الصفحة، يعني لا السهم شغال انه يقلب ولا ده ولا ده، اي ولا ده ولا شيء. اوكي
كده الانتر.
ايوه
وترجع الباك سبيس يرجع ورا.
دقيقة هذا الانتر يجيب لي الصفحة اللي بعدها.
ايوه
اوكي شكرا. هذا الكلام طالع عنده ولا مخبى الان؟
لا طالع.
اوكي طيب شكرا. Sorry, some problem in that. Now, what's ergonomic? Ergonomic is to make everything in the OR in a convertible way. Like when you have an orchestra, they're all working together to give you a good climate of work. So it's a study and design, the situation taken into occupation, anatomic, physiologic, psychologic variability, everything going together in a nice way. Okay, now we have a lot of impact in our body. Every day we have a lot of, for example, operation, the need of the patient, what he needs, instrument problems on us, stress of the staff, the environment, many things. So how to make these in a good situation? So we need to have a good visualization, the light in the room, manipulation of the instrument around us, TROCAR, target, bed, patient, the posture itself. Mental and physical workload also should be in a nice way. And the operation room, talking about table and monitor and the gas insufflator, the camera, everything should go in a smooth way. Now, what we do, in fact, we insert our scope, one camera, maybe 2 or 3 other, sometimes 4 instruments, and direct it to the target. The most common target we are doing is the gallbladder, next to it appendix in the laparoscopic surgery. Now, what's going on? The adequacy of exposure of operating field, position of the scope is very important. We have to choose a place of a scope that gives us a wide view in the area, okay? We prefer always, if you are working the pelvis, you can use scope number 0. But otherwise, we prefer 30 degree or 45 degree. Now, position of the patient and table. Just remember, always the patient should be on the table in a fixed modality. We have to fix our patient on the table, on the bed. And then we have to put the bed as much as possible down, because simply, if you look at the instrument, you will find they are long. The instruments, they are long, you see, 35 centimeter and more, sometimes 45 plus. So that's why we have to put the bed lower down to decrease the problem on the shoulder. I will fix the patient because simply we may raise up the bed at the head side. We may lower the head down if we're working the pelvis, or we tell the patient right side up, left side up, and so on. Now, movement of the camera and holding assistant should be in a smooth way. Zoom in and zoom out, and to show the field completely without any blind spot. Scope, it gives you the target, okay, and define the optical axis that should be on axis. I will all explain it. and direction of the view toward the target itself. Now, as much as we concentrate the view at a 45 degree, we are going a good focus on the image. Yes, you have any question? Next. That's it. Now, we put the optic target, the scope as 30 degree. Number one, once we go in an open technique, I don't use at all the Veris needle. It's a blind technique. We cannot develop any training facility on a blind technique, and we cannot gain experience on a blind technique. Still, the open technique has a minor injury than a blind technique as Veris. As much as possible, the open technique may injure a bowel like the Veris, but never, the open technique never injure a major vessel. Okay, that's why we don't use a Veris needle. Now, this is an optical axis. Once we go the camera, first we look at the site of insertion, make sure there is no injury. And then we move as a panoramic view all over. Then we target our goal, like a gallbladder. At the same time, the angle always of the scope between 45, 60 degrees, this is a good angle and give us a wide view. The center of the visual field, always the optimum visuality, okay? The side, they are more darker, okay? So I have to concentrate in the center. And the eye coordination with the monitor, it facilitates the hand movement also at the same time. I will just skip this one. And this is what I mean. Our brain, the eye, and the hand and the operators. Okay. This should go always in a smooth manner that we can see the target easily and focus our job on it. Now, monitor position. We'll go here.
ماهر خش على
Do you have any question? Okay. Just make it a simple way. If I put a screen, I want to do, for example, laparoscopy. So I put the screen on the right shoulder, okay? And the screen, just in an easy way, mostly the screen, either it's a normal screen or it's a high definition, we can just put it between 120 to 140 centimeter away from us. And the screen should come exactly on the level of my vision, not higher up, so make a neck pain, not lower down, so again, cervical pain. Should be exactly on the same level and at the site of the target. So if I want to do an appendectomy, I move the screen to the right iliac fossa. Simple as that. So I walk toward the target. This is simply, if I am doing the surgery with my elbow almost 90 degree or even 60 degree, it will be more flexible. I don't want to do surgery like this. No, it should be like this way. That's it. The distance, this is what I told you exactly. So we'll take it between 120 to 140 centimeter away. Insertion of instrument, any instrument go inside should be under vision, okay? And always we make the skin more I mean the skin opening more than the instrument, so it doesn't make much pressure. And I will show all this on our skill lab. Now, trocar inserted. Now, certain fulcrum affect the instrument. As I said, the incision, its size itself, misorientation of instrument, if I don't know how to coordinate myself. There is mirror skin natural location of operative field or inverted. This is all related to the surgery I'm doing and the experience of the one who's holding the camera and the surgeon himself. So they can overcome all this if assistant holding the camera, he knows how to hold the camera. And the surgeon put the trocar on field in an on-axis way, not on off-axis, and he target the goal. Placement of the trocar, again, this is all related surgery. I don't want to go much about this, but really, if we do a good training on the skill lab, on the video and simulator, all these will be optimal. Yeah, we'll have a good surgical practice. I know how to handle the camera. I know how to insert the trocar, insufflator in an open technique. All these I will come through it once I do a skill lab training in the skill lab here. No, this one I will skip. Yeah. Now, if I do everything in a correct way, that the bed on the right level, and I elevate the head, for example, I put the screen at the target exactly on my level, away 140 centimeter. And also I fix the patient. I put the trocar in the right way. Still, as long we do all this in laparoscopy, the rest still is the main joint that is affected. I can relieve the shoulder with all this job and the elbow and cervical and my vision, but really we cannot do much about the rest because still it is instrumental work and it will cause some sort of pain at the rest. To provide an optical target view degree for best task performance, how to solve this problem, adjustment of the width, the height of the level of the bed, optimal trocar insertion, all these can help to overcome the problem related to laparoscopic surgery. Suturing, the best is always vertical. To do suture on this way, which is photo number 8, is the best. Now, if I do it horizontal, to do suturing, you have to be vertical, even in the skill lab, because this is an easy way. If you go horizontal, it's much, much difficult, okay? And this is just explaining the problem. The angle between the camera and any trocar should be around 60 degrees. This, take it in a simple way. Distance between camera and trocar, not more than 10 centimeters. The same, the other trocar. Now, between trocar and other trocar, from 10 to 20 centimeters in an easy way. If you look here, that your vision is like the camera, and you're doing the keyboard, the computer tapping. This is the same way when we insert the camera, and you can see the fork and a knife like this. They are on axis, and they are working with you toward the target. Camera is just behind, okay? Now, this is what I just explained, 10 to 20 centimeter, and the ideal 60 degree. Again, if I put the camera, I have to put the visual field complete. No blind end at all. Complete visual field. We'll do it now here. And this will allow convertible movement within the visual field. Again, this is the on-axis, and that I can see the trocars on the field. Now, off-axis like this. Look at this. This is camera opposite to them, completely opposite to them. Okay, and this is another way of difficult off-axis. The procedure will be much more difficult. In a conclusion, so center of the field, better in illumination than periphery, appropriate magnification of the field, no blind spot, and there should be a training for the camera, the surgeon, in the scilla, slow, steady movement, not a jerky movement, so you'll feel dizzy. Should be smooth movement in, zoom out, and to show up the right side or the left side or the ceiling, which is the abdominal wall. So practice and practice and practice. Best performance of the axis is perpendicular to the target, as I mentioned, 45 degree. This one is skipping. Manipulation elevation angle between 45 to 60 degree, and the trocar between 10 to 20 centimeter far away, 10 centimeter from camera, from each of them 10 to 20 centimeter. Operation on axis, I mean me as the camera and the trocar toward the target, not opposite each other or side. Monitor in front of the surgeon. Now I will show you something which is on the camera. I will call them. I'm sorry, calling them to give the camera on my view. I want to show you how to use all this in the scilla. By the meaning, scilla will help us a lot in practicing before we go to laparoscopic surgery, even basic surgery and other, not just examination help. Scilla is made to give a big help for our teaching purpose, so we can apply it on live after practicing on it. فأبغى أنا الكاميرا توري هذا لازم يظهر يكون باين اللي هو باين مرة واضح هنا. تقدر تكبره في الشاشة؟ لا، أنا لو شلت أنا شلت الفيو حقي، تقدر تكبر ده كله بدل ما يكون شيء مربع صغير. ما يكبر. طب هو عندهم ظاهر كذا
ايوه عندهم ظاهر بس
صغير.
صغير كمان.
لا،
في حد يسمع؟
لازم في طريق انه
في حد يسمع؟
ما اعرف، بس في اكثر من شخص كانوا باينين صورهم.
عشان سنة بس كيف الكاميرا عندهم؟
ما اعرف. شوف علي الزهراني. الله.
والله دكتور انا هشوف من هناك الكاميرا كبيرة ولا لا.
طب انا اشتغل يعني عليه ولا كيف؟
تمام. دقيقة. بعدين يبغى يشوفون الكاميرا كبيرة كيف؟ الحين تشوفها كبيرة؟ طيب هو نبغى مظبوط يعني خلاص.
هاي.
خلاص عشان قفلنا الباوربوينت.
فاذا الان طيب كده.
كويس كده؟
اوكي. طيب بسم الله. Now, of course, our screen here is lower down, but this is only a dry box. The other screen هنا تقدر تفتح لي اللابتوب. I can show you now. For example, this is some target. We can see them here. And I want to go now. This is, you see, on axis. This is again on axis. And have this one. Yeah. Okay. The target is this piece here. If I catch the piece, this one to hold, and then I try to put it on this area. Okay, so now this helped me training to focus. Number one, to focus, how to get the related piece. Yes, get the piece, then focus it and put it in a suitable one like this. So this is on axis. This is the target. I move it again, take it, put it in another one, okay? And like this. The training of this make a coordination and it orient me how to use the instrument, and again to focus how to it's much easier one. Okay. Number two, if you look at here, proceed the task module. أعمل هنا. طيب وبعدين كيف؟ افتحها. Now, فين البروسيدر؟ clipping and procedure. يفتح. بس منظر بدون ماوس ولا ستاتيك كان ورك؟ هذه
ايوه.
one, two, push the instrument forward, set the instrument, push. This must insert the instrument all the way. Push the instrument forward, okay, and bring down them as close to each other. ما اشتغلت؟ ليه؟ Feel at the same time, the same level, and as you see, all these allow you to work in a nice way that the elbow is not high like this, it's lower down, and give a 45 to 60 degree. So it is exactly when you work on it like when you work in the OR. في حاجة قول له ما هي شغالة. الصدى من هذا التاسك ونقفل. ما بيشتغل جبنا هذه ودخلنا الانسترومنت زي ما قال كده جوا، بعدين سحبنا وقربنا ولا اشتغل. هي طيب وليه أول ما فين؟ أوكي. هي بس ليش هذول ما اشتغلوا؟ سيزر وأبغى جراسبر. كليك، فين الكليك؟ كيف؟ نجيب على ده أصلا هذا كده. طيب بعدين يبقى كمان سيزر. سيزر نعم.
هذا ما شاء الله. شوف
كده انتهينا.
ايوه في اشياء ربما اعرفها.
عبد الرحمن سويت كذا هو يبغى يسوي يصرف
ماني ما بتبان الانستا، انا بشوف الانستا بالجو. انا ما اعرف هذا الكلام، زمان كنا دائما ندرب عليه، بطلنا ندرب عليه. صار عندكم فيو كمان
ايوه
يعني هذه جديده. لا ابغى توها جراسبر وابغى كليك وبعدين سيزر. او ده اللي عارف برنامج هذا قول لي كده. برنامج القديم كان اسهل تقدر ايش كليك المكاتب. طيب وده اللي حصل، انا لفيتها وبعدين سحبتها. لا لازم تعمل كلوز. ايوه
بعدين اذا كان مناسب تعمل له فريز من عمل فريز.
ما تلعب.
بس تعمل فريز
ابغى جراسبر هذا وبعدين كليك الثاني وبكليك هذا. ايوه فين عاد؟ كيف؟ ان شاء الله. Okay. Now this is the side of the infundibulum. I hold infundibulum with the grasper. Then we go inside. We put a clip. Okay. And one more clip. And one last. Now دحين ابغى سيزر ايش اسوي؟ كليك تو ريبليس.
ايوه خلاص بدخل
اللي هو هذا.
ايوه
هو ايش اعمل الان؟
كليك. ايوه تبغى هذا او تنزل.
ايوه خلاص.
اسحب شويه كمان الهاند اليسار شيء بسيط عشان يطلع معك تو لاين صار
and then I go like this and I cut it. So now we have a double clip on the distal part here, and we have one clip here, and then we can go to next part like here. في أسحب كده وأفتح. كليك. الآن كليك.
الان خلاص.
and we go.
اسحب شويه اليسار.
ليه؟
لانه ما بيعمل كليك وما بيحسبها بالجهاز الا لما تكون مساحه اليسار مفتوحه.
بس قفل.
بس ممكن يلعب فيل.
ليه؟ اهو.
شيء بسيط.
هنا.
اسحب.
اسحب كمان. خلاص. ليه؟
لما تسحب يعطينا شو اسمه
ايه.
لاين ازرق على شو اسمه حق الار3 هنا.
ايوه.
على اساس انه خلاص كذا.
طبعا قفلنا بس الان. مقفول.
ايوه
من هنا ومن هنا.
تمام هو صح الطريقه صح.
انا يعني ممكن احط كمان.
بعد كده
دبل
سيزر.
الان سيزر اسحب. لا. We take a hook scissor, for example. Extract tool to reinsert. Okay. هذا هو. This is a hook scissor. And we go and we cut. So you see that task completed. By this way, we could simply train them on the most difficult part, which is the cystic duct clipping and division, also the cystic arm. Of course, you can continue and go to the next task and dissect the gallbladder from the bed. Then the next to it, how to remove the gallbladder and put it in a pouch and come out with it. Now, if we do a training in the skill lab on the right way like this, next step to train, not to train, to do it on an actual patient will be much easy because we have already having the full ergonomic modality to make the OR in an easy way, not in a difficult way. This is all about my talk. Thank you so much today. Any question you can ask. Nick, هم يسألوا أحيانا ولا ما؟
بعضكم يسأل بعضهم.
ممكن ما يسألوا. طيب أجل أنا أقول لهم إذا كان you have no question يعني جينا على هذا المصلي. Thank you. If no question, it's okay. See you later إن شاء الله. Thank you so much. أعطيني بس هذا يصير أخرج من
فلاش.
أي الفلاش. وجزاكم الله خير.
الله يعافيك.
الله يعافيك. يا أخي كنا بالأول بنطلع الريزدنت باستمرار يعني بالتريننج. والله يساوم أحسن. الآن نزل مستوى. لازم نرجع مرة ثانية نعمل التريننج.
شوف ايش الجدول
ولا سكيج ولا الجدول كلم محمد ناصر. هو ماسك البروجرام. أنا كنت أيام البروجرام ممنوع أحد ينزل يعمل لاب